The following brief presentation, about 20 minutes in length, describes a framework for medical practice providers, managers, and support staff to understand the essentials of value-based care initiatives. We refer to that framework as the 3 R's: rules, resources, and representatives. I'm Mike Delmonico, your host. I've been a medical practice executive and consultant for 30 years. I have no business relationships or conflicts to disclose related to the content of this presentation. Value-based care initiatives are changing on how healthcare delivery is organized, valued, and paid for in the United States. The observations and tools contained within this presentation are intended to provide a framework for medical practice providers, managers, and support staff to understand the essential elements of these diverse, evolving, and growing arrangements. The content for this presentation is based on an article titled Essentials for Transformative Healthcare Delivery Success, published in the October 2021 issue of the Medical Group Management Association's Connection magazine. New information has been added to this presentation since the publication of the referenced article to maintain its content as current and up to date. This first section of the presentation will review the changing state of healthcare delivery and payment. For medical practices in the United States, the traditional and still predominant methodology for healthcare delivery and payment is known as fee-for-service. The fee-for-service approach to paying for healthcare delivery is transaction-centered and values the units of healthcare services delivered as evidenced by diagnosis and service codes, thus the name fee-for-service. The evolving and growing methodology for healthcare delivery and payment is known as value-based care. The value-based care approach to paying for healthcare delivery is patient-centered and values the quality, effectiveness, and efficiency of the healthcare services delivered as evidenced by a wide range of actions and outcomes, thus the name value-based care. Examples of the actions and outcomes considered in value-based care arrangements will be described later in the presentation. Government and commercial health insurance entities, otherwise known as payers, are driving experimentation and innovation with healthcare delivery and payment methodologies. The primary government agency involved in the development and sponsorship of value-based care initiatives is the Centers for Medicare and Medicaid Services, otherwise known as CMS. As the largest healthcare payer, CMS has a huge influence on the future of the entire U.S. healthcare delivery and payment system. Two recent publications by CMS, the Innovation Center Strategy Refresh and the National Quality Strategy, have established some notable goals for the future of value-based care initiatives, including all people with traditional Medicare and a vast majority of people with Medicaid will be in accountable relationships with healthcare providers by 2030, and government and commercial value-based care initiatives will align quality reporting and payment standards in order to accelerate the growth of such programs. Like CMS, there are many commercial payers engaged in value-based care initiatives across the range of their respective plans and their respective covered beneficiaries, children, adults, and seniors. Medical practices may participate in multiple different value-based care initiatives simultaneously. For that reason, having a framework, such as the 3 R's, for understanding and distinguishing from among the variety of arrangements is a key toward having success with each. Medical practice participation in value-based care initiatives may be arranged directly with payers, or may be arranged through partnerships with entities, such as accountable care organizations, independent practitioner associations, and clinically integrated networks, otherwise known as organizers. Value-based care partnerships between such healthcare entities, medical practices, payers, and organizers communicate a great deal about their patients held in common. Value-based care partnerships also communicate a great deal with their patients held in common. The traditional fee-for-service model for healthcare delivery and payment has required very little of medical practices beyond the use of an electronic medical record to document patient assessments and services provided, and then to submit claims with accurate diagnoses and procedure codes for payment. The newer value-based care models for healthcare delivery and payment create organization-wide challenges for medical practices to transform their existing infrastructure, staffing, systems, and routines in order to succeed with these new methodologies. Key transformation goals for medical practices and their partners, payers and organizers, are to develop sophisticated abilities with information management, information analysis, patient engagement, care management, and care coordination. Advanced healthcare information systems and analytics, along with high levels of patient engagement, are used to identify opportunities to promote wellness care, disease prevention, chronic care management, care coordination, and appropriate utilization of services, which will overall result in enhanced care delivery quality, effectiveness, and efficiency. A few notable observations that I have read about value-based care include value-based care is already leading to better care at lower costs, but even greater value can be expected over time. Value-based programs require substantial organizational change, and value-based care isn't simply a different approach, it's a revamping of processes and an investment in practices and people. It's a mindset. That all said, the fee-for-service model has not gone away, and value-based care models have not taken over. The revolution against high cost and disorganized healthcare delivery and the evolution toward patient-centered, cost-effective, and coordinated healthcare delivery are ongoing simultaneously. For now and the foreseeable future, medical practices must be able to demonstrate expertise under both healthcare delivery and payment paradigms, fee-for-service and value-based care, in order to get paid optimally. Now, with an understanding of the changing state of healthcare delivery and payment for medical practices, this second section in the presentation introduces the 3 R's framework for understanding value-based care initiatives. Value-based care initiatives may seem daunting as they are diverse, dynamic, and evolving, and very different from the traditional fee-for-service methodology of valuing and paying for healthcare delivery. Although it is a CMS goal to align the form and function of value-based care initiatives in the United States, there is currently a great deal of variability among initiatives by payers and organizers, their benefit plans, and their beneficiaries. For those reasons, the 3 R's work well as a framework for medical practice providers, managers, and support staff to organize their understanding of and participation in value-based care initiatives. The 3 R framework for success consists of know the rules, master the resources, and engage the representatives. The first R is know the rules. Value-based care arrangements come with rules. The rules are the most detailed, dynamic, and complicated features of value-based care initiatives. The rules require medical practices to develop new staffing, systems, and routines never before required by the traditional fee-for-service methodology. Rules can change from year to year and sometimes can change in the course of a year. Rules are a mix of healthcare delivery science and the current healthcare delivery and payment priorities of the respective payers and organizers. There are 4 primary rule components to know for each value-based care initiative. First, who are the providers and patients attributed to a given plan? What healthcare delivery actions and outcomes are valued? How are healthcare delivery actions and outcomes valued and paid for? When are healthcare delivery actions and outcomes valued and paid for? For the first rule component, who are the providers and patients attributed to a given medical practice? Under value-based care initiatives, healthcare delivery must be determined accurately and verified frequently. Attribution is the assignment of responsibility for healthcare delivery, quality, effectiveness, and efficiency to a primary care provider and/or practice for designated patients. The medical practice must understand the attribution process as established by each payer and organizer and frequently audit the roles of both the primary care providers and the patients who are being associated with the medical practice. Any combination of incorrect or missing providers and incorrect or missing patients will result in performance measurement inaccuracies and must be corrected. Your medical practice should only be held accountable for those providers and patients who are actively part of your practice. For the second rule component, what healthcare delivery actions and outcomes are valued? Those healthcare delivery actions and outcomes that are valued are currently determined by the priorities of the payers and the organizers. A future goal of CMS is to have the priorities aligned across all payers and organizers, but for now, that is not the case. Although you may find examples that differ, here is how I categorize healthcare delivery and actions. A quality measure tends to be scientifically derived and is generally accepted as evidence of healthcare delivery accuracy and correctness. An effectiveness measure tends to be process-oriented and is generally accepted as evidence that healthcare delivery happened on a timely basis. An efficiency measure tends to be financially derived and is generally accepted as evidence that healthcare delivery happened in the most appropriate setting. This next slide includes some detailed examples of performance under each category. Healthcare delivery quality may be evidenced by preventive and wellness care, vaccinations and screenings, and chronic care monitoring, tests, and treatments. Healthcare delivery effectiveness may be evidenced by pre-office visit preparations, annual wellness visits, screenings for depression, fall risk, and other conditions, and managing transitions of care. Healthcare delivery efficiency may be evidenced by total cost of care less than budgeted projections. The third rule component, how are healthcare delivery actions and outcomes valued and paid? Healthcare delivery actions and outcomes may be valued and paid in a number of ways. A few of the more common examples include discrete payments made per unit of action, such as payment for every depression screening or fall assessment completed by the practice. Payments per attributed member may be made, such as $5 per member per month, in support of a medical practice infrastructure, such as the existing of a care management program or recognition as a patient-centered medical home. Discrete payments may be made based on complex formulas with weightings and thresholds used to calculate a share of healthcare delivery savings generated by the practice. And lastly, payments may be made through enhanced fee schedules when paying claims. How the healthcare delivery actions and outcomes are valued and paid, whether by units of action, on a capitated basis, by complex formulas, or through enhanced fee schedules, is currently at the discretion of the respective payers and organizers. The fourth and final rule component is when are healthcare delivery actions and outcomes valued and paid? Payers and organizers determine when healthcare delivery actions and outcomes are valued and paid. Valuation of results and subsequent payments may occur quarterly, monthly, or annually. For examples, infrastructure payments on a per member per month basis in support of medical practices care management program or patient-centered medical home recognition might be made monthly. Discrete payments for the number of healthcare screenings completed might be calculated and paid quarterly. Shared savings payments based on weighted scores and thresholds might be paid annually after the payers and organizers have collected and analyzed all the prior year's data on the cost of care. So, as previously mentioned, and as you can see, the first R, the rules, is the most detailed and complicated aspect of the framework. Now on to the second R. The second R is master the resources. Health information platforms and analytics are some of the most important resources needed for success with value-based care initiatives. Reliable and real-time information is key to stewarding the right care at the right time in the right place. Reports and information guide medical practices on healthcare delivery priorities and process improvement tactics. To facilitate the collection, analysis, and exchange of data between medical practices, payers, and organizers, sophisticated health information platforms are utilized. These are the key resources that make value-based care initiatives possible. These health information platforms track real-time patient-specific information on receipt of wellness, acute, and chronic care services, the completion of tests and test results, patients who are high utilizers of services, and transitions of care, such as admissions, discharges, and transfers of patients to and from healthcare facilities. Payers and organizers will adopt specific health information platforms that meet their needs and interests. As a result, medical practices find themselves challenged to become proficient with the functionality of multiple different health information platforms from various payers and organizers, along with the multiple different sets of rules previously mentioned. In addition to the variety of health information platforms to master, medical practices must also decide on how to assign responsibility for health information management. Will the responsibility for interacting with the platforms, generating reports, and analyzing data be assigned to a specialized department of the medical practice, deployed to each of the medical practice locations, or a combination of the two approaches? Mastering the functionality of payer health information platforms through a centralized, decentralized, or hybrid approach will impact the timely and effective use of information. The third and final R is engage the payer and organizer representatives. The payers and organizers recognize the existing demands on medical practices and the new demands that value-based care initiatives present. To deliver on expectations and projections of these newer healthcare delivery and payment methodologies, payers and organizers have marshaled a new generation of representatives to support the success of medical practices with value-based care initiatives. Representatives could technically be considered resources within the 3R framework, but they are deserving of their own category by virtue of their distinct contributions toward achieving success for the entire value-based care partnership between medical practices, payers, and organizers. With traditional fee-for-service models, payer representatives act as network builders, fee schedule negotiators, and claims adjudication problem solvers. They tend to be reactive in their roles and meet with medical practice executives when issues arise. With value-based care initiatives, payer and organizer representatives act as rule translators, resource educators, and medical practice transformation coaches. Representatives are proactive in their roles and constantly creating opportunities with medical practice providers, managers, and support staff to identify tactics for generating healthcare delivery quality, effectiveness, and efficiency. So now, in section 1 of this presentation, we learned about the changing state of healthcare delivery and payment and the value-based care initiatives that are evolving and growing. Then, in section 2 of this presentation, we were introduced to the 3R framework for understanding value-based care initiatives: rules, resources, and representatives. In closing, there are 2 key takeaways. First, fee-for-service and value-based care methodologies currently coexist, so medical practices must be proficient with both models of healthcare delivery and payment in order to succeed. Second, more and more patients will be connected with value-based care arrangements in the future through both government and commercial payers. So medical practices will need to develop the infrastructure, the staffing, systems, and routines that support heightened patient engagement, care management, care coordination, and information management. With so much value-based care experimentation and innovation ongoing, knowing the unique rules, resources, and representatives associated with the different value-based care initiatives and partnerships is essential for gathering the intelligence and abilities needed for medical practices to adapt and succeed. Understanding the 3 Rs will lead to awareness and recognition by medical practice providers, managers, and support staff of where practice transformation and innovation is needed to meet the demands for healthcare delivery quality, effectiveness, and efficiency. I hope that you found the preceding information and the 3R framework for understanding value-based care initiatives helpful. You can contact me with any questions at my email address below.